Hey everyone, Dr. Matt Geller here. Welcome back from the break. Super excited to continue on with the show today. I hope everyone is enjoying Eyes on Dry Eye and having a great time. I'm very excited for our next guest, Dr. Doug DeVries of Eye Care Associates of Nevada. Let's bring him on. How's it going, my friend?
Hey, Matt. I'm doing well. How are you doing today?
I'm doing well. You know, the stress has finally subsided. The build up to the event gets crazy. Then you get into it and you go, finally. So we're having a great time. Attendance has been awesome. Education phenomenal. And thank you for joining, of course.
Absolutely. Pleasure too. And what a great event. I mean, what a great service to the profession.
Yeah, you know, I just keep thinking about how everyone come Monday, unless they're seeing some emergency dry eye cases on Sunday, you know, you can't help but go back, to clinic on Monday and just be excited about treating dry eye or diagnosing dry eye, whatever it might be. Everyone is going to be charged up from it. There's no doubt about it. So jumping into the first one here, you know, I want to talk MGD prevalence. And it's interesting. We ran a survey, right, on quite a few ODs. And for everyone out there, this is in your conference bag. You'll be able to review all of this data for free, right? We've included it. And this is on page 17. And when talking about prevalence, we asked these ODs, this is 757 respondents on this particular question, how frequently do you check meibomian gland function at of your patients while at the slit lamp? And that was a 6.85 average score, right? And then also, do you feel that screening for meibomian gland dysfunction is part of a comprehensive eye exam? And we got about 84.7% yes, 15.3% no. And I thought it was just, you know, such a very interesting topic, and it could be kind of dissected in a few different ways. But, you know, I want to ask you specifically, you know, do you perform meibomian gland expression to assess gland function? Do you use the meibomian gland evaluator? Tell me about kind of your practice patterns there, and even feel free to reflect on those stats.
Yeah, absolutely. And I think that those the stats should be higher because I do believe it's part of a comprehensive eye exam. You know, they have the terminology non-obvious MGD and obvious MGD. Well, it's only non-obvious if you don't or diagnostically press on the meibomian glands and take a look at the quality of the meibum. So yeah, it's actually part of every routine exam that I do. And we also include meibography in those individuals who have a speed score higher than 6, along with some point of care testing. Mm-hmm. But when I look at the eye, we're looking at structure versus function. So meibography itself will give us the structure, but we need to press on those meibomian glands and tell the function. Now, you asked the question, meibomian gland evaluator. Yes, that's a good tool to see with the normal blink pressure how much meibum you get out. But even beyond that, then I want to press a little bit harder to look at the quality of the meibum and make that determination. Is it baby oil-like? Do we have some turbidity? Is it discolored, or is it thickened and paste-like? And then grade that meibum accordingly. But unless you actually diagnostically express those and touch it, and it just takes seconds to do that as part of your exam. Mm-hmm. If one of my residents or one of my students is in the room with me and they don't have a Q-tip in their hand or a cotton tip applicator to press on those lid margins, you know, I'll just mention to them, so we're going to do an abbreviated slit lamp exam today, because I think it's that important.
Yeah, and clearly there's levels to this, and there's the ability to get better and better at it, faster and faster with it, and kind of know what to do and when to do it, and I love it. And I think the other side of it too is explaining this all to patients, right? Reflecting the importance, or not only what you're doing, but the importance of what you're doing, and maybe even touching on what is meibomian gland dysfunction. So how do you get that across to patients?
Well, I think it's really important when you're doing a comprehensive evaluation on a patient, and you look at, if you have meibography, you can certainly show them those pictures and show them what normal is and show them what the atrophy and what their glands are actually doing. And then when you diagnostically express to show that patient, I simply explain, just like I did, normal oil that is secreted from the eyelid margins to help hold the tear together and to keep it from evaporating looks like baby oil. And let me describe what your meibum looks like based on me taking a look at it, and in addition, looking at this meibography or looking at the imaging. So then I correlate the structure with the function. And I'll tell you, Matt, patients get it when you do that. When they say, you know, this is normal, here's yours, this is what the oil looks like, patients seem to really understand. And what I follow up with the patient then is, at some point during this treatment, we're going to address the acute nature of your dry eye, but we're going to have to address the lids. So I'll mention that right at the very first exam when I'm talking to somebody, that we're going to have to address the eyelid margins and the progression that we're seeing, to stop that progression, because we have a finite number of glands and we don't want to see any more lost.
Yeah, 100%. I think that's such a key message to get across. There is a finite number. They don't just, I mean, there is some recovery that can happen, but they don't just spring back to life if they're too far gone. So have you seen cases in your practice where you've really stabilized the tear film in patients with meibomian gland dysfunction, particularly with LipiFlow, and seen that positively affect contact lens outcomes, contact lens comfort? I know we have some sessions on that here at the show, but I'd love your take on that.
Oh, I don't think there's any question, and it's supported well. And my clinical experience mimics a lot of the studies as well, is that it is going to increase comfort of contact lens. A lot of the studies will show on an average of 4 hours that it increase the wearing time. And that's clinically what I've experienced as well. Patients are just more comfortable, able to tolerate their lens, and quite often get through their day, where before it was falling short of really getting through their full workday.
Yeah, and I mean, I'm sure you've seen your fair share of cases, but what does success look like, both particularly clinically, after a LipiFlow treatment or after maybe a few? What does that success kind of spectrum look like for you in, I guess, average patients?
Matt, that is an absolutely great question, because success takes many forms.
Mm-hmm.
I mean, when you have a lot of atrophy in a patient, you have very thickened meibum and you're hardly getting any meibum out and maybe just out of the upper glands, then if I'm able to look at that patient, I'm able to gently express or use a meibomian gland evaluator, and now I'm having success by getting that meibum, that is something that I can relate to the patients, because it's so interesting. When you initially see a patient, they could say something like, at the 1 month visit, yeah, it felt a little better for a while, but I'm not feeling that much difference at this point. And then you look and you press on the glands and say, well, I'm really impressed at the number of meibomian glands producing good secretions now. So I'm real pleased. And they get very enthused at that particular point. And I think it's important to remember that with the neurotrophic component that can advance sometimes, and I'll tell all my patients, you may not feel what I'm going to see. So you may have to rely on, my evaluation. Now down the road, that'll probably get better, but initially you may not feel what I see.
Yeah. It's interesting. We're talking about before and after with patients. Tell me a little bit about just before and after with your practice, before having LipiFlow, after having LipiFlow. Maybe just a quick story, or, it's probably been a bit for you now, but can you reflect on that?
Well, yeah, certainly, and I think another good question. I mean, I've been using LipiFlow for a lot of years. I'm one of the earlier adopters that took the technology on. And honestly, Matt, I can't imagine practicing without being able to do thermal pulsation on a patient, without being able to offer that as an option, because there are such limited options and nothing really compares. So it goes back a number of years, probably, 8 years, 9 years. And it just has completely changed the way I practice, the way I talk to patients, and the encouragement that I can give patients that we can make a change in what they're feeling.
Imagine just being stuck with the old tools and only those old tools. I feel like thermal pulsation particularly, and obviously LipiFlow being, really the key player and first mover on the scene, has just kind of spurred quite a lot of innovation in dry eye in particular. There's just something very unique about when thermal pulsation devices like LipiFlow came on the scene and what followed after. And you're right, it was maybe a little bit boring prior to that. And, I keep saying in these segments, as optometrists, we love innovation, we love new devices, we love the toys. And so how can you practice without one? It seems kind of archaic, right?
Well, and you look at what the innovation that's occurred. If you look at the 2007 DEWS report, MGD was not even mentioned. I mean, it wasn't the treatment, identifying it, really moving on. The treatment really wasn't identified for dry eye. And with an 86% prevalence in your patients with dry eye, I just can't imagine practicing without it now. And then the 2017, I mean, it is right up there as a thing that you have to look for, you have to address, you have to treat, and have it within your practice.
Yeah, and thanks for citing the data. It's always impactful to have that. Let's talk about implementation. And one thing that always I found so valuable, whether I was reading articles or journals, whatever it might be, was kind of like the scripts. Like, how do you tell what exactly what words should you use to talk about, in this case, meibomian gland dysfunction and LipiFlow to a patient? What does that sound like? How does that dialogue go?
Well, the dialogue, and it's so important in addressing patients, because you have to let them know really the importance of this. And I think a lot of that is done with meibography. And when you explain to a patient, this is normal, here is your meibography, these are tortuous meibomian glands, these are obstructed, these are actually have atrophied and segmented and dilated. We show that patient. So we show them normal, we show them, and just said, we're going to have to address this. And then it's so interesting. All you have to do is use a little correlation with the patients of saying, I bet every time you walk outside and the wind is blowing or it's cold, that your eyes start watering. And they'll say, yes, it does. That's exactly what happened to me. Well, that's because the tears are evaporating so fast and the atmosphere is actually getting to the surface of your eye, which it shouldn't. That blink or that tear should stay in place between blinks. And I think relating that to the patients and showing the image, and I'll tell you, I thought I was pretty good at describing that. Before I had meibography, with meibography, there's no comparison. Patients get the whole concept of this is normal, this is mine. And something that I've borrowed from Paul Karpecki over the years is when I describe that to the patient, I'll actually kind of move next to him and say, what I'm looking at concerns me. And that's that loss of the meibomian glands. And it truly does concern me, because I see these advanced patients where they have lost significant meibomian glands, and I don't want that patient to follow the same path. So I think using terminology about it being concerned and this is normal and these are yours and there's something we can do and we need to be proactive and we need to take this. So I just tell them that we're going to start the acute nature of their treatment, but we're going to have to address those lids at some point.
Yeah, I like that you're bringing the emotional side into it, that bedside manner piece that seems to be missing from so many doctor interactions these days, not just eye care, but that's such a critical piece to get your patient understanding that you really do care. But yeah, back to that, prior to LipiFlow, LipiView, LipiScan, the devices, I mean, what could you use to show them anything? It's like, I think about posterior segment care, and it's like, oh, I don't have a fundus photo. I'm just going to kind of draw on this piece of paper. I remember that in optometry school, sketching out the retina, and it's a game changer for sure. Another thing I'm always kind of interested in is the patient flow, right? Think about that patient journey. I've done some lectures on that. What is the particular patient flow for someone who, whether meibomian gland dysfunction patient, potential LipiFlow patient, does the staff bring it up first, or are you first to bring it up? What does that look like? And I think implementation is key. It's key for docs to know that those steps in order to be successful themselves.
Yeah, Matt, you've hit the nail on the head. And if clinics have the technology and they're not utilizing it, it has everything to do about patient flow, and it has to be smooth. What we do in our clinic is we start out with a questionnaire. That's the low-hanging fruit. We want a patient to tell us they have a problem. And if it's 6 or above on the speed score, what we do is we then automatically do meibography, inflammation, and osmolarity. And at one point when we started out with meibography, we would actually we'd actually talk to the patient, see if they wanted to sign an ABN, have the test. No longer. I consider the meibography the Snellen visual acuity of dry eye, and I need to know. And it's going to lead to so many downstream procedures, so many visits with the patient, and increased in really helping that patient overcome their problem, that we think it's in our clinic very important to do that as part of the workup when they're 6 or above. If they don't score 6 or above on the speed score and one of our doctors see it, then they're going to go ahead and they're going to capture those images and have the technician. But for workflow, if you can have it automated where something triggers the scans and then they're done, and the question, who brings it up to them first? I mean, what my technicians will say when it's displayed on a 42-inch screen is that the doctor is going to have this printout. He's going to go over and show you what your meibomian glands and what this imaging look like versus normal. And they don't go much further than that. But at that point, the patient is waiting to hear information on, well, I wonder if this is normal or not. And then when I tell them and look, and if they have loss that I'm concerned about this, you physically see them lean forward to listen to you when you say that, because they're very interested when they've found out what they have on their imaging is not normal. So, but patient flow is everything. You have to streamline it. So if people have this technology and they haven't been utilizing it completely, it's because of patient flow. And then also, I mean, having staff on board that when you start a sentence, they can finish it. Everybody has to have the same dialogue. So if I go through something and they can repeat it for scheduling and looking at procedures to do, then the staff helps out that as well. But everybody has to be on board. But no question about it, the flow is what makes the difference in our practice for the number of procedures we do.
Yeah, getting everyone in sync is so important. I mean, the coordination for this event, there's so many little pieces going on, and if we weren't in sync, you know, there'd be issues. And I love that it's how can my staff members finish my sentences? How can I finish theirs? The patient feels that for sure. Now, what about for ongoing treatments, and how do you express to patients the importance of that should there be a need for ongoing treatment?
Well, I'm going to emphasize to the patient, because of their condition, that their physiology wants to drive toward inflammation and hence obstruction of these oil glands. That's just their physiology. And I'll say, you know, just like some people will want to create cholesterol, some people will have hypertension, even they don't have some of the other risk factors, that's your physiology. So not only are we going to remove that obstruction, but we have to look at what else can we do to help that. And that's the, you know, ancillary type of equipment, or not equipment, but a treatment that we'll do. You know, I have patients then make sure that they're doing a warm compress afterwards on a regular basis. I will also have patients on one of the anti-inflammatory dry drugs to hold down that inflammation. So I let them know that they are active participants in making this procedure last as long as they can. And when I see somebody that's reobstructing, and the key is you got to bring them back. You got to take a look at it again. You got to press on their meibomian glands. If I see somebody that's obstructing, say after a short period of time, 9 months or a year, I'll ask them, you know, about the rest of their therapy. Are they continuing with warm compresses? Are they staying on the rest of their therapy? And quite often they'll say, yeah, I'm not really that good with it. That's good, because they're accepting responsibility for their condition, because all we can do as doctors is identify, recommend, treat, and then the patients have to be in concert with what they're going to do to stop their physiology or reverse their physiology a little bit.
Yeah. And who in your office particularly, or maybe that you've seen with friends and colleagues, who discusses treatment cost, and how does that part sound, and any tips there?
Well, and what I do is, again, on the first encounter with the patient, I'll say we're going to have to do something about the lids. I'll make sure my front desk gives you literature and pricing on these procedures.
Got it.
And but if they press me, I'll tell them. I'll say, you know, here's what the cost is, and explain to them that there's, you know, that we don't have the codes, that we don't have the reimbursement on that, but but I'll also tell them there's a lot of very medical procedures like LASIK that don't have insurance coverage on it as well. So I just relate. And then in cosmetics, and there's so many, in dermatology, there's so many of those procedures. And so the patient seems to be, you know, accepting that. If they press me, I'll tell them. If not, my staff is the one that goes over and explains those things.
Got it. And yeah, and it seems like up to that point, they've had enough visuals and enough of the clinical description and enough of the here's how we're going to do it, that part becomes a lot easier. It's addressing the why and the how, right? And allowing the staff to help support you, and the closing of that message is a nice way to do it.
And my staff is also trained that if somebody says, you know, that's a little too much money, I don't know, you know, and they will then start talking about patients that they have seen and how they've responded. And they'll say, you know, the doctor feels so important. Even if you do one eye at a time, go ahead and do that. And then invariably, if you do one eye, they're coming back and they're doing the second eye as soon as they can afford it. And that's the beauty of the LipiFlow procedure, is you can do independent eyes and just do one at a time. So I think that's a real advantage as well.
Yeah, no, absolutely. It totally is. Is there any other closing remarks prior to us heading into the next session here?
Well, I just say that meibomian gland dysfunction is so prevalent and so important. I mean, the study that Priya Gupta did recently in looking at her pediatrics, she's a pediatric ophthalmologist out of Duke University, and she looked at 150 of her patients between age 4 and age 17. And shockingly found a 42% incidence of clinically significant dropout in that patient population. So, with computers, with nutrition, we're seeing it sooner and sooner. So regardless, just make it part of your exam come Monday morning is where you just take a little sterile tip applicator. It's only going to take you 5 seconds. Press on those meibomian glands. And then you will see within your practice what in your patient demographics, how much treatment you could be providing to patients, how much better care you could be providing, and you'll know the prevalence when it comes to making a decision on whether or not to purchase the technology. You'll know within your practice how many of those patients exist.
Yeah, thank you for sharing that. Dr. DeVries, it's been an absolute pleasure. Thank you for coming on and sharing all of this wisdom. For those of you out there, be sure to write in your conference bag, you've got the 2021 dry eye report, and take a look to see where you kind of land on some of these averages, and you'll see that you're not alone in kind of entering the journey of dry eye here. And Doug, I mean, sharing this wisdom is invaluable for those excited to get more into dry eye, and I'm sure these pearls of wisdom will be invaluable.
Oh,
So
wonderful.
thanks.
You're absolutely welcome. I'm passionate about this because I love seeing patients move and say, I just can't believe how much I'm better since I started seeing you, and the thermal pulsation is an integral part of that success.
Yeah, no, absolutely. Well, I appreciate it, and we'll catch everyone in the next session. Thanks.
Thank you, Matt.